Brilliant. Well done, everybody. I think there's more than 50 of you in the room.
Brilliant.
So fantastic to get through all of this again for another day of fun and games. We're going to start with a variety of sessions. This one taking over from the Cauda Equina session last year. And then into the afternoon, where we look at more political things with a variety of fascinating talks in between. So without further ado, I'm going to introduce you to Nigel Henderson, who's going to be the co-moderator in this session.
Yep. Thank you very much for attending. I just want to make an introduction to the whole session because we'll bring it all together, really. And part of that will be, if you've got questions, please put them into chat. And we'll deal with all the questions at the end of the three talks. I just wanted to emphasize that over recent years has rightly been a focus on the diagnosis and immediate management of Cauda Equina syndrome, driven by the desire that these injuries should not be overlooked and that the surgical management and timing should be optimal. Indeed, we spent time yesterday afternoon in a whole session considering those issues. However, regardless of the early management, many of these patients are left with neurological deficit, which may be minor and transient or profound and life-changing. The management of these deficits in the early days and weeks following neurological injury is vitally important in maximizing recovery, and they should not be overlooked in the busy, often spinal, surgical or orthopedic wards or follow-up clinics where people don't understand them. And mismanagement by the failure to recognize them and refer for early specialist rehabilitation is a real miss. So you must deal with them. So I'm going to introduce our first speaker, Gillian Harrison-White, who herself has suffered serious consequences from Cauda Equina syndrome. But it is important to recognize that she's been a nurse, actually, for 30 years, working in various roles in the NHS, from orthopedic wards to sports injury specialist and overnight responsibility for hospital stop. She's gained many postgraduate qualifications, including emergency nurse practitioner, a large A&E department. So she's seen these problems from both sides, but her recent years following Cauda Equina syndrome, she has been passionate about raising the profile of this condition and working with associated charities and formulating pathways to deal with it. So without any further ado, I'll just open up Gillian's talk. Here we go, I think.
Good morning, everybody. My name is Jill Harrison-White. I'd like to thank Nigel Henderson for asking me to speak at the BritSpine conference. I'm here to give a very, very brief overview of my Cauda Equina syndrome. You'll note I'm an emergency nurse practitioner working in a very large A&E department in the Midlands. So going back to 2014, I had some low-lying back pain for about a week. Nothing untoward, nothing that I couldn't self-manage with over-the-counter medication. On the 8th of August, the pain started to get a little bit worse. It started to radiate into my left bottom cheek. Nothing untoward that I was really concerned about, but I was increasing the analgesia that I took. I went to bed that evening, and as is normal practice, I always used to get out in the middle of the night. When I got out in the middle of the night, I struggled to initiate the flow of urine, and that was something that I noticed a change in. Went off back to bed, was in a lot of pain, don't get me wrong. I got out of bed about 8 o'clock the next morning, the 9th of August, and as I took 2 steps from my bed, I collapsed on the floor. I had a horrendous pain in my back, down my left leg, but it just collapsed and gave way. At that point, an ambulance was called and it took me to our local A&E department, where I was assessed by a registrar very, very quickly, a full neurological assessment done to understand what was going on. So low back pain, as I say, it was there for a week, but it got worse in the previous literally 12, 15 hours. A little bit of left-sided sciatica, but nothing that I could really write home about. Nothing on the right side whatsoever. Loss of power to the left leg was noted in A&E. It was 1 out of 5. I had reduced anal tone, very evident. And this is all within 2 hours of literally getting out of bed that morning. I knew I desperately needed to pass urine, both at home and also when I got to the A&E department. We tried several attempts to pass urine on the commode, a bedpan, in the toilet, and nothing was happening at all. So a bladder scan was done. It showed 540 mils at that point, and a decision was made to catheterize me before I went off for my scan. I didn't feel the catheter going in. Distinctly remember asking my colleague, had she put it in? It was already in. They did a catheter tug. Again, I didn't feel that. So there were some red herrings that were showing up at that point. I'd got no reflexes below my left knee. I couldn't do a straight leg raise at all. There was no plantar dorsiflexion of the left foot whatsoever. And saddle anaesthesia was noted on the Asia chart to light touch and pinprick. And that was at my initial presentation to an A&E department. Went off for the MRI scan, which you can see a brief picture of mine on the left-hand side, which shows a large prolapse disc on L5-S1. Past medical history was a spondylolisthesis at L4, L5 as a teenager because I was a competitive swimmer and it was putting quite a lot of added strain on my spine at the time. Events that followed. So I went up for the MRI and then straight up to the trauma orthopedic ward where I saw a spinal registrar who actually did another neurological examination. Cauda equina syndrome was being mentioned to me. Discussions were in place in relation to me going to theatre that afternoon, and I was told I was nil by mouth. He just needed to speak to the spinal consultant on call. This was a Saturday afternoon when that telephone conversation took place with a spinal consultant on call, who wasn't on site, who didn't have access to my scans, and he was only going on the information passed over to him from the registrar. He advised to give me strong analgesia, for a trial without catheter and watch and wait. And he would see me in 48 hours time on the Monday morning. So I was a little bit alarmed by that, but nevertheless, that was the consultant's instructions. I had a TWOC 12 hours later, and subsequently I went into painless retention on the Sunday afternoon with over an 800 ml bladder. That was very, very well documented in my medical records. And that was done to try and prove whether this retention was due to pain or whether it was due to the disc. 48 hours later, the spinal surgeon saw me. He categorically denied that this was cauda equina syndrome. He documented that it wasn't cauda equina syndrome. It was a large disc prolapse with radiculopathy. And surgery didn't take place until 9 days later. And that was at my insistence because I wasn't progressing, I wasn't mobilizing, I didn't have the power in the leg, and nothing had changed with the bladder and bowel. I remained catheterized throughout the hospital stay, and I had no voluntary bowel function throughout. That was managed by appearance laxatives administered by the spinal nurse specialist. Post-operative issues. I've suffered quite a lot, despite no diagnosis of cauda equina syndrome. So drop foot has been there since 2014 and still got it now. It's very heavy, it's dense. When I've done too much walking, if I've done a shift at work, it becomes very clumsy. I can trip more than fall. Chronic pain I've lived with. Again, I just take over-the-counter medication and some neuropathic drugs, namely in the form of amitriptyline and gabapentin. Never taken any codeine or opiates, and I don't really wish to. I've always been able to void voluntarily post-op, although I've not had the sensation that I feel a full bladder. In the sense I can go right through the night now without having to get out to use the bathroom. Chronic constipation has been the main problem for me. About 9 months to a year post-op, I started to gain weight and abdominal distension. About a stone I put on. Coupled with a decreased appetite, I could eat about 5-6 mouthfuls of food before I just couldn't eat anymore. I started to become short of breath going up one flight of stairs at home. And this is me, who was very fit and active. I was swimming several times a week. I'd got back to work. Yes, I'd got some issues, but shortness of breath started to worry me. The sexual function has always been there, but it wasn't the mainstay of the problem. When I started to become short of breath on the most minimal of exertion, I went to the GP, and she started to do some investigations, namely in the form of gynecological ultrasound scans. They all came back negative. So we had an abdominal x-ray done, which showed that I'd got a fecally loaded bowel all the way around from the ileocecal junction right round to the rectum. I had no pain in my abdomen whatsoever. At that point, I was admitted to hospital, and I stayed there for 7 weeks. These are the pictures that I took during this quite distressing period in my life. When I was in hospital for 7 weeks, I was allowed out at the weekends, just to give me a little bit of freedom. But I was on copious amounts of laxatives up and down both ends. I had an NG tube down directly into my stomach, putting laxatives through that way, and they were also attacking the bottom end as well. I was also started on transanal irrigation. As you can see, it was grossly distended. I was having significant breathing problems. I had diaphragmatic splinting, which was evident on a chest x-ray at this point. My saturations were really low at 89, 90% on air. And I was really struggling to even hold conversations with people. I was off work for many, many months at this point. So after 7 weeks in hospital on a gastroenterology ward, I still had no answers. I didn't have a diagnosis of cauda-equina syndrome. I just knew I had a dysfunctional bowel. So at my insistence, I went up to the spinal injuries unit in Sheffield to see Mr. Thumbicat in December 15, where we talked about a bowel regime. We talked about a possible neurological injury, i.e. CES. He wanted some anorectal physiology studies done to prove or conclude otherwise what was going on here. He wrote a letter of instruction to my local hospital where those tests were to be carried out, and he advised on a bowel regime. So I went to the pelvic floor service in February 16, and they started having conversations with me about ileostomy, laparotomies, a world that I really didn't want to open up at this point because I still needed some answers. So although I was put on a waiting list for surgery, I decided to still search further. I went to St. Mark's in Middlesex as a private patient to have the anorectal physiology studies done. And it concluded that very same day by the consultant telling me that this was a chronic cauda-equina injury. I had a neurogenic bowel. I was 22 months post-spinal surgery at that point. You'll see from the pictures, my bowel was at the point of no return. It was so fecally loaded that I couldn't even function. My respiratory function was compromised, and there was no going back. I had to go ahead with the colorectal surgery. That took place in July 2016. I had a laparotomy and a defunctioning loop ileostomy. That defunctioning loop ileostomy changed my life in this fact that I really couldn't understand what went wrong and why I ended up in that situation. I decided to start a legal process, something that none of us of healthcare professionals would want to be part of. We don't like having to justify some of the decisions that we made, whether that was in the patient's best interests or not. But I needed personal answers as to what went wrong, why I was effectively told otherwise, and I had been denied access to services for a cauda-equina injury purely because I was told I didn't have cauda-equina syndrome. So anyway, that legal journey started and ended last year in an out-of-court settlement. It's done. I had a lot of psychological issues having a stoma. It was something that I didn't want. I didn't feel that I needed. I had a lot of body image issues, lack of confidence, my self-esteem hit rock bottom. So going out, my social life became impacted, mixing and socializing with friends. I would say 2016, 2017 affected me more psychologically than physically, because I was trying to come to terms with everything that I'd found out, what I'd had to go through and how it was impacting my life. It also started impacting my marriage and my relationship with my youngest son. So much so that we actually parted separate ways in 2019, very sadly. And and counselling is currently ongoing. I don't wish to go into too much detail about that because it's quite a personal situation. My work and career has been very heavily impacted in the fact that I was the wage earner in my marriage. I worked full time. I was a sister in the urgent care centre. At the time of the injury, I've had to have a job role. I've had lots of reasonable adjustments put in place in relation to times and shift times to manage all my treatments and therapies. I only work part-time now. And I live alone. My career was always something that I wanted to develop as my children got older.
Nothing that I could self-manage with over-the-counter medication. On the 8th of August, the pain started to get a little bit worse. It started to radiate into my left bottom cheek. Nothing untoward that I was really concerned about, but I was increasing the analgesia that I took. I went to bed that evening, and as is normal practice, I always used to get out in the middle of the night. When I got out in the middle of the night, I struggled to initiate the flow of urine, and that was something that I noticed changing. Went off back to bed, was in a lot of pain, don't get me wrong. I got out of bed about 8 o'clock the next morning, the 9th of August, and as I took 2 steps from my bed, I collapsed on the floor. I had a horrendous pain in my back, down my left leg, and it just collapsed and gave way. At that point, an ambulance was called, and it took me to our local A&E department, where I was assessed by a registrar very quickly, full neurological.
I was doing irrigation through a stoma after work every single night for several months. And it's something that, you know, it was taking up a lot of my time after I'd been at work. This was my family time, something that I didn't want and shouldn't have had to have been doing. So I was in discussions with my colorectal team at St Mark's about having a panproctocolectomy. That essentially went ahead in November 2019. I had the whole large colon removed, and I've got an end ileostomy now. It has very sadly left me with malabsorption and nutritional deficiencies, but I do manage those with medication. So currently, well, I'm on long-term sick at the minute. I've actually got a large prolapse disc at L2, L3, which is causing nerve compression again on the left-sided only. I'm actually due to have surgery this coming Monday, the 22nd of February, for decompression. So hopefully all will go well again there. It's giving problems with my upper leg this time, my hip flexion and my quads. Counselling's ongoing. As I said earlier, the legal case resolved last year in an out-of-court settlement without any prejudice, on a gastroenterology ward. I was trying to come to terms with everything that I'd found out, what I'd now do self-catheterisation several times a day. Stoma problems. Well, I had a defunctioning loop ileostomy, which gave problems in the sense that fecal matter was still backtracking down the distal loop of the colon. My large colon was still intact. And you might not see from that picture, I had a very flat stoma that was flush to my abdomen. And at night time, it was literally filling up the large colon again, causing abdominal distension. And again, we then had the same problem, how to get rid of it. I was doing irrigation through a stoma after work every single night for several months. And it's something that, you know, it was taking up a lot of my time after I'd been at work. This was my family time, something that I didn't want and shouldn't have had to have been doing. So I was in discussions with my colorectal team at St Mark's about having a panproctocolectomy. That essentially went ahead in November 2019. I had the whole large colon removed, and I've got an end ileostomy now. It has very sadly left me with malabsorption and nutritional deficiencies, but I do manage those with medication. So currently, well, I'm on long-term sick at the minute. I've actually got a large prolapse disc at L2, L3, which is causing nerve compression again on the left-sided only. I'm actually due to have surgery this coming Monday, the 22nd of February, for decompression. So hopefully all will go well again there. It's giving problems with my upper leg this time, my hip flexion and my quads. Counselling's ongoing. As I said earlier, the legal case resolved last year in an out-of-court settlement without any prejudice, without an apology. And that was something that I really, really needed to achieve. I'm currently supporting other patients with Cauda-Equina syndrome through online social media and raising awareness. I've done various talks now at study days for nurses about neurogenic bowel and how to manage it. So something to think about. Well, I had a unilateral posterior lateral Cauda-Equina compression, something that is very rare, but it does happen. And, you know, I'd like you to think about being honest with your patients, their relatives. I've asked lots of times throughout this journey of mine at various clinic appointments what I thought and what I suspected. And it was always dismissed, my thoughts. Again, I always wanted an apology. I did get an apology from the chief executive last summer in a face-to-face meeting that I arranged. So, you know, for me, that chapter's closed. I'm moving on. As you know, Cauda-Equina cases cost the NHS millions every single year. And just something to think about. I found myself piecing together this jigsaw, something that I shouldn't have had to do.
Gillian, thank you very much for that. It's a very brave thing to come and talk about something so personal to a group of people you can't even see. Lots of issues raised there, from diagnosis through to the long-term management of various aspects of your care. So thank you very much. And this is really the theme that's been taken up by my colleague, Alan McLean, who works down the road from me in Glasgow and sees all my mistakes. So it's very nice to see Alan and welcome him talking about the hidden disability in Cauda-Equina syndrome. So Alan, thanks very much for coming, and here's your talk.
Hello. My name's Alan McLean. I work at the National Spinal Injuries Unit in Glasgow. I'll tell you more about that in a second. I'd just like to thank the organisers very much for inviting me to speak at BritSpine 21 on Cauda-Equina hidden disability. I think this is a very important subject that is overlooked by many people, including ourselves. And I think these are an orphan group that do need to be looked after. And maybe in the discussion, we can discuss who's best to look after them. I think it's useful to give a bit of background as to who I am and what I do. So I'm not a surgeon. I'm a physician, and I work in the National Spinal Injuries Unit, the other National Spinal Injuries Unit in Glasgow. And it's important to get an idea of what we do. So we serve a population of about 5 million people. And we are tasked by our commissioners to look after specifically traumatic spinal cord injury. Now, that is quite a subtle difference from many people with Cauda-Equina problems. So there's obviously a huge amount of overlap there. But explicitly, we look after people with traumatic cord injuries. And of course, some of these have got lower spinal injuries, lower lumbar injuries, and they do end up with Cauda-Equina problems. So we see a lot of people with bladder bowel problems that we'll come on to later. However, what we don't specifically do is look after people with disc disease. We do by default end up with a few people that have had major central discs. But the reality is, for a lot of these poor people, is that there are simply too many of them for the spinal cord injury services. I don't know what things are like in your part of the world, in other parts of the UK, and other parts of the world outside the UK. I know some spinal units will take people with disc disease, some won't. It's a tricky area. I think it probably comes down to capacity and our ability to look after people. My feeling in Scotland, from what I've seen, is that I suspect we'd be overwhelmed if we took in everyone with disc disease. We would very quickly fill up a lot of beds, and you end up with an overlap into people who maybe haven't got straightforward central discs, but have maybe just got, well, not just, but they've got sciatica, back pain, mild bladder bowel problems. Should we take these or not? I don't know. We can discuss that later. We take about 150 patients a year, and I reckon we probably see about 10, 15 with good going Cauda-Equina problems. So what kind of people do we see with Cauda-Equina problems? Well, a lot of them will be familiar to many of the audience here. It's very simple, relatively simple. If someone's got a low lumbar injury, anything from L1, even T12 downwards, they may have intact legs, but they've got clear-cut bowel, bladder, sexuality problems. They've had a horrible fracture. These people are really pretty, not easy, but they're straightforward to pick out. And I think most of our patients are picked up very expertly by the doctors in the emergency department or in the orthopedic or neurosurgical services. They have major trauma. They've definitely got neurology. They may have weak ankles. These ones are fairly straightforward, and we'll probably get them within a day or two of injury and start assessing and treatment. I think the difficulty in diagnosis that I certainly see in my clinical practice is people who have had trauma, which I suspect is more relevant to the group we're addressing today. People who have had trauma, they've had a low lumbar injury, they seem to be okay, but then they turn up, they're discharged, and then they turn up at the orthopedic neurosurgical clinic follow-up, and they've got problems. And I probably see about 4 or 5 people a year who have been through the orthopedic neurosurgical environment. They're thought to be neurologically intact, but on reflection, looking back, they probably aren't. And I'm pretty sure of the scenario that's happening with these people. So if we look at the Asia form, which I'm sure you're all familiar with, this is the International Standards for Neurological Classification of Spinal Cord Injury, which we use in the spinal cord world for documenting people's degree of spinal injury. Now, if someone's got a really serious paralysis, it's usually clear, isn't it? They'll usually have a clear-cut sensory level, a clear-cut motor level, and immediately the alarm bells are ringing. Get this form out, study them closely. It's pretty clear they're paralyzed. Emergency treatment, fixation that come to a spinal unit. I suspect the problem arises with, if you use this form correctly, looking down at the sacral segments here, you see we've divided, for those of you that haven't seen this form before, we're looking at 28 dermatomes here. Looks complex, very simple actually. This is designed the most unintelligent doctor can assess a patient just with a rubber glove and a safety pin. We've got 28 dermatomes. If we come down to the dermatomes here, this is right side, this is left side. So what we're asking people to do is just to check the light touch and pinprick sensation in the lower sacral dermatomes. They're even marked out on the Asia man here. And we want to know light touch, pinprick, S2, S3, S4, 5, that's perianally. Do they have voluntary anal contraction? And on the right side here, can they feel deep anal pressure? Can they feel a figure in their bottom? Now, this looks really straightforward. It's very clean clinical document. I think you can ignore the subscores at the bottom, but the actual examination's very straightforward until you try to do it. And I think anyone that's tried to do an Asia form in a patient who is distressed, has got distracting injuries, maybe an oxygen, they might be ventilated, in which case you can't do anything. They will be unwell, they may be hypoxic. This is actually, I think the difficulty of doing examination properly is really underplayed, I think, by spinal injury experts as much as anyone else. We glibly talk about it, but it's a really complicated thing to do properly. And to try and get a sensible history from someone and a sensible examination when you're sticking pins, you've only just met them, you're sticking pins in their bottom, you're brushing cotton wool against the bottom of their private parts, asking them yes or no, you're scoring the sensation. It's actually a tricky thing to do. And I believe, and I think people working in spinal injuries are very guilty of this. We downplay the difficulty of doing this properly. It's actually, especially in the acute scenario, this is a difficult test to do. I think this test has really been designed for a bit downstream, maybe a week, 2 weeks after injury, when people are fully alert and can cooperate. We see half of our patients within 40 hours of injury. They're still confused. Some of them are still under the influence. Difficult thing to do. And I think what happens here is that this bit down here, I'm just circling this with my my cursor. S1, 2, 3, 4, it's difficult to do properly. PR examination, difficult to do properly. And I suspect what happens sometimes is that major sacral problems get overlooked, not through any negligence or fault examining doctor, just simply it's a difficult thing to do when you've got a patient with polytrauma, major spinal injury, trying to decide whether their pinprick sensation on their S3 is STUD score 2, 1, or 0 is quite tricky. And I have a lot of admiration for anyone that tries to do this in the acute scenario. It takes myself, I probably just one of our registrars or other junior doctors. It'll take us 40 minutes to do this properly in a alert, intelligent, cooperative patient. And that's not a scenario you find very often. So I think what happens here is that we collectively as doctors, we do miss people with cauda equina problems. And probably about a third of the people I see have not had this diagnosed, had not had the problem diagnosed at the time of injury. So how are we going to diagnose cauda equina syndrome? Well, in essence, everything is going to go floppy. We're looking here at damage to a lower motor neuron nerve, so everything is floppy. Bowels are floppy, bladder is floppy, penis is often floppy as well. So there's generally a detuning of the nervous system. I'm going to get rid of that. But sometimes the diagnosis can't be it's not as straightforward as that. People may have very subtle bowel and bladder problems that only become apparent after a few days, weeks, or even months before it's absolutely clear they've got cauda equina problems. Of course, radiologically, we're going to have almost certainly now a CT scan if it's a trauma case, and an MRI looking at the nerve roots, the lower spinal cord and the nerve roots. There doesn't seem to be a great deal of concordance between the degree of damage seen in the MRI scan and the degree of damage actually of clinical symptoms complained by the patient. And I'm sure we've all seen people who have got really quite severe symptoms, very bad bladder bowel problems, and remarkably normal looking MRI scans. And this is where I think the title of this talk I think is really useful, Hidden Disability. And of course, for many of these people, if they've got involvement of the lower sacral segments, their legs will be normal or near normal. They may complain of sciatica or some leg pains, but the majority of these people, they're going to have pretty much normal legs and normal gait. So to all intents and purposes, after the initial trauma or maybe a big central disc, these people will actually look normal, they will walk normally, inverted commas, and they will behave, inverted commas, normally. So this, I think, is where we really get problems, both for health professionals and for friends, family, and loved ones, in that it's a very much a hidden problem. So we now need to look at how it affects the various systems and how these interact. Well, firstly, the biggest single problem is bowels, second biggest problem is bowels, third biggest problem is bowels. We have found in our unit, certainly, maybe other people have different experiences, but if you can't clear the bowels out regularly, everything else goes wrong. Most of these people have got a paralyzed low motor neuron bowel. It's really like a big shopping bag of feces. It will not empty normal. They'll often have a patulous anus. They've got very little continence. They've got no sensation of the urge to defecate, and they're chronically constipated. And that is a number one thing we see inevitably. Patients coming from any other unit, they will have bad constipation. They may not move their bowels for a week, 2 weeks, 3 weeks. And what happens then is there's knock-on effect to their bladder and sexuality as well. Providing the bowels can be regulated, then everything else flows from that. So it's a pretty horrible situation for the poor patient. And I think it's pretty horrible for a lot of doctors. I think a lot of nurses and doctors are very good at dealing with bowel problems. I think an awful lot of people would rather not deal with bowel problems, and they would rather give out clever drugs and look at more intellectual pursuits. But we know in the spinal units, unless we get the bowels regulated, nothing else will get better. Everything else will go wrong. So what we usually do with people with this, the first thing, the key to this is understanding. They've got to understand they have paralyzed bowels. And a lot of people haven't been told that. We'll tell them, I'll tell them, but a lot of other doctors and nurses will be reluctant to tell them. They've got to know that bowels do not work properly, and they will need to take laxatives, and they'll need to take them for the rest of their lives. And that, I'm afraid, is a rather brutal truth I give to a lot of our patients. If they've got established cauda equina damage, they're not going to get better, and there is no point taking laxatives for a couple of months and then stopping, because undoubtedly they'll get constipated again, all the problems will start again. So units use different regimes. We usually advise people take something at night like Senna, which helps load up the lower bowel. Then in the morning, they usually need to do a manual evacuations. Positories generally don't work, they just fall out. So they usually need to use a gloved finger to empty the lower bowel. It's pretty horrible stuff for the average person in the street, and as I say, for a lot of doctors as well. But they've got to clear their bowels out, preferably every day, maybe every couple of days. If they don't do that, they will get constipated and all the other problems will get worse. So this is where you really need to have a sympathetic attitude. I'm sure we've all got sympathetic attitudes, but some of us more sympathetic than others. In our unit, we're lucky enough, we have excellent nurses who can really have frank discussions with the patients about this. I like to think I'm reasonably good at it, but we've got fantastic nurses who take time to get to know the patients and go through this really unpleasant procedure with them. Now, the key thing here is that if the patient gets it, if they understand they need to do their bowels every day, forever, they will probably be okay. If they don't, they're going to run into problems, and we see the same face coming back time and time again. I think that's our failure. It's not the patient's failure. It's our failure as a profession, as doctors, as nurses, in not getting this message through to people. They need to look after their bowels with regular medication and manual evacuation, probably forever. And that's a term I use with people. To come on to peeing, most of them have got big floppy bladders. They've got very poor detrusor or no detrusor control or power, and they've got no sensation of fullness. Most of these people need to go on to intermittent self-catheterization. Again, a big step for someone who's never done this before. And you really need their situation there with nurses, doctors who know what they're doing. Probably in the end, nurses take on the bulk of this work with discrete discussions in outpatient clinics and on the ward. I think this is where we're fortunate. If we have patients as inpatients for a few weeks, you can teach them these things. I think trying to teach them personal bowel and bladder care as an outpatient is just about impossible. And we'll often try and get people in for a week or so. If they've come to us from elsewhere, we'll admit them for a week or so to teach them what to do and how to do it. The third area, of course, that's hidden is sexuality as well. Female sexuality, not really a lot been written about that, but certainly they lack clitoral sensation. And in men, of course, it's more dramatic in that they are impotent without sensation as well. Now, this is an area where I'm afraid drugs like sildenafil don't really work, because you need intact pathways. You need the reflex pathway intact. Of course, that's been broken. And that means that drugs such as sildenafil are unlikely to work. So probably resort to mechanical means of getting erections, or alprostadil injections. And again, this is the kind of thing which needs a discreet and sensitive clinic setup, not the kind of thing you're going to do in 5 minutes in a busy neurosurgical orthopedic clinic. You're going to just need a specialized area to do that. And then I think one of the hardest things with cauda equina syndrome is this idea of it being a hidden disability. I think the hardest thing some of our patients have to deal with is that they look great. They've often had major trauma, or maybe they've had a slipped disc, as it's known. Friends and family, spouses know they've been into hospital, they've had an operation, possibly. They've come out, they look great. And we hear this time and time again. Everyone thinks they look great and congratulate them having made a great recovery, slap them on the back. Very happy for them. The poor patient smiles and accepts the congratulations, but inside they've got major bowel, bladder, sexuality problems, and they often don't speak to anyone about it. They don't speak to their friends, colleagues, workmates, wives, husbands. And I've had a lot of people who no one knows about this, because it's a miserable condition. It's very personal issues, these bowel, bladder, and sexuality. It's a very hard thing for some people to cope with. Some people are very frank and upfront and will tell everyone, I've got these problems. A lot of people won't. then it becomes difficult because they may be questioned as to why they're applying for certain benefits, why they're applying for a blue card for driving because they need to be close to toilets, why they need a radar card to get into public toilets and so on. And I think that's one of the hardest things. And I think we've got some patient representatives speaking today, which is absolutely great. And I'm sure they'll have a view on this as well, be able to come up in a discussion. But I think it's a very hard thing to cope with. I think one of the things we do at our clinic, I like to think it helps, is that we let people know that they're not alone. There are many hundreds, if not thousands of people in Scotland alone who've got this problem, and must be tens of thousands around Britain. They're not alone. There are groups that can help. There's the Spinal Injuries Scotland, where I am, the Spinal Injuries Association for the rest of the UK. There's various Code Equina groups. They're not alone. There is help out there. And I think sometimes I'd like to think that if these patients, even knowing they're not alone in itself, is a very useful thing to know. So my message is to be aware of people with lower lumbar injuries. Are they really neurologically intact before they go home? Are they really not got any bowel bladder problems? Someone like me, very happy to see them if you're not sure. And if they do have bowel bladder problems, I think these are best managed in a holistic setting, in a spinal injury unit. I think individually, a urologist or a bowel expert or a sexuality person probably isn't the right setting for these people. I think they need holistic care from a department like a spinal injuries unit that can look at all three of these together, as well as psychological impact. Right, well, thank you very much for listening to me in that short discussion there. And I understand there'll be discussion later on, but I'm very happy to join in with that. Cheerio. Thank you.
Right, thank you very much, Alan. I hope people can hear me. What we'll do is move straight on to Pradeep's presentation, but I just want to say, first of all, I've been looking at all the comments coming through in moderation. There's a vast number of comments as well as some questions. I've moved most of them over because they're worth reading, but we're not going to be able to deal with necessarily every question at the end. But as I say, there are some comments worth reading in the chat. So Pradeep is a consultant surgeon spinal cord injuries at the Spinal Injuries Centre based at the Northern General Hospital, part of the Sheffield Teaching Hospital Trust. Obviously, his work covers all aspects of spinal cord injury management, but he has a particular interest in pressure ulcers and the management of the tetraplegic upper limb. He's leads the education committee of the British Association of Spinal Cord Injury Specialists and is on the specialist advisory committee of the Royal College of Rehabilitation, Royal College of Medicine in rehabilitation. So thank you very much, and we'll get you started. Thank you.
Good morning. I'm going to be talking about potential skin-related problems associated with cord equina syndrome. And I'm basing my talk on our experiences with pressure ulcers in people with spinal cord injury, including cord equina syndrome, at the Sheffield Spinal Injuries Centre. So this is what I'll be covering. And that is me. And I'll be talking about some aspects of the pathogenesis of pressure ulcers, specifically in relation to cord equina syndrome, risk factors, and a brief overview on management. So when it comes to pressure ulcers, I think it goes without saying that prevention is the best form of cure. So there is nothing else that beats preventing a pressure ulcer. Anything that we can do to prevent a pressure ulcer sort of reduces morbidity and saves a lot of money. And we know that it works because since pressure ulcers became a reportable problem in the NHS, there's been much more attention focused on it, and consequently there has been a significant decline in the frequency with which serious pressure ulcers occur. So in terms of pressure ulcers, most people are aware of the EPUAP grading, And what I would like to highlight here is that sort of grade 1 pressure ulcers, where there is no break in the skin but non-blanching erythema, this is the time at which intervention makes a difference. If you can pressure relief at this point, the induration and the skin erythema settles over a few days, and the patient can resume a normal level of activity. Whereas if it gets to grade 4, where there is extensive tissue destruction, it is going to be associated with quite a considerable amount of morbidity. And by the time it gets to grade 4, what one has to remember is that there is almost always an extensive amount of destruction underneath the skin, which is the most resilient of tissues. And this is often referred to as the cone of necrosis. So in clinical practice, what you usually find is a small opening in the skin associated with a fairly large cavity, often containing necrotic sloughy tissue. So this here is a grade 1 non-blanching erythema, at which time it responds well to pressure relief, and and that may take the form of bed rest. It may take the form of removing a splint, and within a few days it settles. Whereas by the time it gets to grade 3, 4, there's quite a bit of tissue destruction, and it can take many months to settle. So with chronic venous syndrome, normally pressure ulcers would not be expected to be a problem because of the relatively low level of injury, discrete neurological impairment, and compared to higher level spinal cord injured patients. And generally, patients with CES are mobile, which also is protective. But what should be remembered is that there is a spectrum of disability, and in those with denser forms of chronic venous syndrome, in the older age group, and in those with comorbidities, they may still be wheelchair dependent and will be at a greater risk of developing pressure damage. So the areas that I want to really sort of bring to your attention are sort of where people have comorbidities, where there is vascular insufficiency, where individuals are unwell and in critical care requiring inotropic support. These factors do tend to significantly increase the risk of developing pressure ulcers. And I do sometimes wonder whether a very prominent sacrum and coccyx increases the likelihood of pressure ulceration. Similarly, incontinence, which results in maceration of skin, often is a significant contributor to skin damage. For those who have lived for a period of time with chronic venous syndrome, there are some additional factors to be considered. Muscle wasting is quite prominent in this patient group because of the lower motor neuron pattern of injury. And so what that means is that there is a significant amount of gluteal wasting, which leads to very prominent bony landmarks, increasing the risk of pressure ulceration. Similarly, in those who are walkers, the imbalance of muscle force around the feet can lead to people walking on the medial aspect or the lateral aspect of the foot. Similarly, clawing of toes and sort of various toe deformities are common, which can all increase the risk of pressure ulceration. As a general rule, it would be fair to say that most grade 3 and 4 ulcers are preventable, whereas grade 1 and 2 can still occur despite optimal precautions. However, those should be picked up and dealt with so that they do not progress to grade 4. There's a separate group of wounds which are not really pressure ulcers, but is often mixed into this group. Now, they are very different and they will not respond to standard measures. And these include wounds where there is deep osteomyelitis, where there is communication with body cavities and communication with joints. These wounds have to be treated as complex wounds and will often require additional surgical or medical intervention to get them to heal. So this is a classic example of one that we were involved with, where a patient had been addressed in the community for about 6 months before he was referred to us, and this is what we found: a dislocated hip. Now, this wound is not going to resolve without without that dislocated hip being addressed. Device-related pressure ulcers are another sort of frequently encountered problem in in this patient group, and that relates to use of splints, incontinence devices, and various other external devices. So this is somebody who had a where a conveyor sheath was applied in a poor manner at the edge of a splint cutting into the medial aspect of the big toe, poorly applied I think this was oxygen tubing that pressed into the neck. An ankle ulcer from a splint that took many, many months and multiple operations to heal. And this here is a sort of protruding penile rod obviously from pressure. So when it comes to management of these ulcers, I think it's fair to say that prevention is key, as I highlighted earlier. Consider patient and environment factors. And sort of the other aspect that I would like to sort of emphasize is that it is not just the nurse's role. So if every clinician who deals with the patient were to think about the skin and look at the skin, there's a much greater chance that that any developing pressure ulcer will be picked up early, but it also acts as a reminder to the patient and as a point of education to the patient in terms of trying to prevent pressure ulceration. Good seating and sleeping surfaces are absolutely essential, and patient education, I think, should be in the forefront of trying to manage these ulcers. The go-to guideline in the UK for pressure ulcer prevention is the NICE guideline. It's a very balanced guideline which was prepared in 2014, and which I was one of the members of the guidelines development group, and it addresses it in a very balanced manner. In terms of managing these ulcers, I think, as I sort of highlighted earlier, pressure relief is key, and this may involve periods of bed rest, taking off splints and doing whatever else to relieve the pressure over the damaged area. Regular dressing, it doesn't matter what particular dressing is used, as long as the principles of moist wound healing, debridement, and pressure relief are adhered to. The vast majority of ulcers, including the majority of grade 3 and 4 ulcers, respond to conservative measures. A minority will require additional intervention, including surgical intervention. Now, an area that is often delayed is wound debridement. And this is something that any one of us in this room can really carry out. I don't know why often there are delays of 3-4 weeks before a wound debridement is undertaken. Effective wound debridement hastens healing, reduces the likelihood of systemic sepsis, and it just makes it easier to handle the the nursing aspects of the wound. Where surgical intervention becomes necessary, this is the approach that is used: dressing to clean the wound, then an excision and closure of the wound using either a primary closure technique or a flap. In summary, I think what I would like to emphasize is that think of the skin in the presence of neurological impairment, because if you get it wrong, it results in a considerable amount of morbidity and cost. Prevention is key. Most pressure ulcers are preventable, and when they do occur, the majority respond to conservative measures. And education of patients and carers is paramount in terms of reducing the frequency with which pressure ulcers develop. Thank you very much.
Thank you very much.
Brilliant. Thank you very much, Pradeep. If there's one message that we can take from that, it's that pressure ulcers are everybody's concern, not just delegated to somebody that you can blame for not doing their job properly. If we all take it on board, they're much less likely to happen. So, great talk. Thank you very much.
Yeah.
Should we go through?
Yeah, go through.
Yeah, about 8 minutes for questions. So, Nigel, do you want to go through the first?
Yeah, there's been a lot of comment and a lot of questions. I think, first of all, the comment, many messages of appreciation and thanks to the presenters, particularly Gillian for sharing her story, which has clearly resonated with, not resonated, but touched many of the audience. A first question that I've picked out, really, or tried to group them together, is do we have an assessment of the size of the problem, the number of patients who are suffering with the consequences of chordal equina syndrome? This is a deliberately provocative question, I think. So, Alan, do you think we have an answer to that?
Gosh, I think you're asking the wrong person. No, except there's obviously a massive well of misery out there. I think England and Wales are ahead of us on this, and that the spinal units tend to take more people with chordal equina syndrome. I think we'd be overwhelmed here. All I can say is that I certainly see half a dozen people every year who have been through the system, through neurosurgery, orthopedic surgery, that come to me, clearly have got that problem. I can only imagine there's hundreds I don't see, but of course it's the tip of the iceberg. I don't know how big the iceberg is.
Gillian,
very clever people here.
Oh, sorry.
Idea.
I was going to ask Gillian, because you've been heavily involved with many of the charities and others, concerned with this, whether you have a feel for that.
I'm involved in lots of social media charities and things, and I'm sort of hearing through statistics that it isn't as rare as what it's portrayed to be, and whether that's through initial misdiagnosis like what happened to me, or they're told different things like I was told, and I think only because of my personality and my background, my knowledge, did I challenge a lot of things. And some people aren't given the correct diagnosis and go on to, I understand they've gone through legal cases. I didn't go through that process for money. I went through it to get some answers because I questioned everything. But I actually think it's a bigger problem than it's not the rarity that we or people are portraying it to be.
Can I make a comment as well? That was the purpose behind the Understanding Chordal Equina Syndrome study that Julie presented yesterday. And what we're trying to do is so many papers are trying to look at how quickly you should be operating, but not looking at what happens to people. And so Julie Woodfield has looked carefully with long-term follow-up, which is at a year, but it'll go to 2 years, following people across the UK with questionnaires on bowel function, sexual function, bladder function, and their motor function, so that we will begin to get an answer to that question. I think the other thing to point out that has been questioning is Manish Desai's paper yesterday from Stanmore that looks at rehabilitation, which was an excellent paper. So he's offered his email address to those who would like to contact him about using similar criteria and a similar regime in following up patients.
I think that there were one or two questions really about surgical technique, what approach, whether we should fuse and so on. But I've passed over those because I don't think they're really the subject of today's presentations. Several people, perhaps alongside yourself, Patrick and Manish, are talking about establishing chordal equina, post-chordal equina pathways. Do you think that's something we should be doing? Patrick, do you have an answer?
Oh, absolutely. I was waiting for the others, but absolutely, this is what we have to do. Fortunately, Sachin and I are about to join the working party to try and make those pathways. So yes, that is what we need to do. As Alan has been saying, it's slightly different in Scotland from England, but we have this awful situation where people come to the clinic and unfold their lives in front of you saying about the hidden disability, and you have 15 minutes to see them and their whole world has fallen apart. And it's just a terrible way to treat people that we don't have enough time to be able to follow them up. Now, other units are very good follow up, and Alan's point that the bowel is so important is something that I see in notes. And when I'm doing medical legal cases, I see the neurosurgical consultant or registrar saw the patient 3 months later, bowel was fine. That means that they're able to pass some stool at some point. But the hidden misery behind that is immense. And unless you have, as Alan was saying, people that can ask the questions and give some advice confidentially and kindly, then I think it escalates the problem, because people feel that they don't have any help whatsoever.
Yeah. There was one provocative question. Do we think that the adversarial legal system is actually contributing to our problem of failure to look, to recognize, to deal with? Who does medico-legal work? Pradeep.
Yeah. What I would say is that the legal system is not responsible for that. I mean, in terms of the communication following the the development of or things going wrong, I think the legal system might have something to contribute, because there is so much more reluctance to say sorry, and again, I'm sort of using a very broad brush there, but I don't think the legal system is particularly responsible for for what happens at the at the very beginning in terms of the assessment and the diagnosis and so on. And I think we talked about sort of access to MRI scans and so on yesterday. And that is, sort of, especially with some of the more atypical ones, and we've been doing a bit of work on infective discitis as well. And the same message comes out that sort of often things are missed, and the quality of examination varies so much between sort of frontline doctors. I mean, if you get an SHO doing it, and this might be the first or second time they're doing it. So there is that, and I think that easy access to imaging will make a huge difference in terms of picking it up early.
Thank you. I don't know how much longer have we got, Henry?
Unfortunately, you are now out of time. May I encourage, this has been a fantastic talk, and I think that there's a lot of discussion around this, seeing the number of questions that have come in. May I suggest that everyone goes into the networking lounge during the breaks and lunch to continue on this discussion?
Yeah, and I think a lot of the things that have come in have pointed to the fact that different people, UKSSB, BAS, CRG, and all the other agencies are also looking to move this forward. Thank you.
Many thanks to all the speakers.
Thank you very much.